Hello and welcome to another episode of Microbially Speaking. I'm your host, Dr. Kevin Stinson. I'm a microbiologist and infection control professional. If this is your first time joining us, then welcome to the channel. Be sure to hit the subscribe button. If you're a returning watcher, then certainly welcome back. Glad to have you here again. I was scrolling through Facebook the other day and I came across this post right here. Post by Liz Wheeler talking about her perception and findings from the diary of Dr. Fauci. And so this is what we're going to spend a little bit of time talking about today. I said I wasn't going to do political topics. All right, we're going to do this anyway. Let's see what happens. So, all of this relates back to the huge release of files from Dr. Fauci's personal diaries that document all of the time right around early 2020 when COVID was coming out. And it's his life experiences at that time, and this is being taken and twisted into a whole bunch of connotations that everything that was done for COVID interventions, public health measures, mRNA vaccines, all of these features, all of these response measures were largely fraudulent. And while I'm confidently able to state that this is probably mostly pure BS, I will attest that I'm not a fluent reader of all 1,100 pages of these diaries, and so I certainly cannot propose to be an expert in every single thing that they say. Today, what we're going to look at, we're going to just look at this post from Liz Wheeler. We're going to take a look at these claims and we're going to talk about them from a scientific lens. Now, there's a lot of claims here. There's a lot to unpack. We are not going to be able to touch on every single one of these in deep detail. If there's one of interest to you that you want to learn more about, let me know in the comments below. We can take a look and dive deeper on a future episode. Right, let's begin. So I'm going to group the first three together because the first three are kind of similar. So we got social distancing was a hoax, masks were a joke, and lockdowns were worthless. And what this is looking at is this notion that public health measures did not entirely prevent transmission, ergo they were false. They were ineffective. And that's a little bit of a difficult fallacy or difficult way to approach looking at this problem. Public health measures are not intended to be unilateral. This will 100% protect you from infection. They're meant to be risk reduction strategies. Nothing is going to be 100%. We often say in public health, there's something called a Swiss cheese model, where you imagine every intervention is a slice of Swiss cheese and it's got holes in it. And if I have one intervention in place, then it's very easy for viruses to slip through those holes or risk to slip through those holes and cause a bad outcome. But if I layer up enough of those slices of Swiss cheese, eventually those holes all become plugged. And that is public health measures in a nutshell. And so social distancing absolutely functions. People look at it from the perspective of, oh, well, if I'm less than 6 feet away from someone, 2 meters away from someone, I should be, I'm at risk. And if I'm greater, then I'm protected. And that should be a black and white arbitrary line, but that's not how that works. And so, if you imagine I'm sitting 6 feet away from you, if I suddenly go to 5.5 feet, it doesn't magically make it so that I'm guaranteed to be exposed. Within 2 meters, within 6 feet, there's a higher probability of being exposed to someone who's infectious, but that doesn't guarantee you're going to get infected. These are not black and white concepts. Same with masks. Masks work really well from a perspective of source control if you are actively sick to help prevent you from transmitting to others. And it's a really good strategy when you have virus that's circulating in large amounts that has asymptomatic infections to mask people to prevent them transmitting. It also does help to prevent you from getting sick by covering up your mouth and your nose. But of course your eyes are still exposed, so it doesn't guarantee your personal protection. And so this is not alone an intervention that's going to completely prevent COVID or any other respiratory virus for that matter. it's a risk reduction strategy. Lockdowns are probably the most complex and the most controversial of those three. And lockdowns are still something that's being looked at a lot from a healthcare policy today. So the concept of lockdowns is very simple. If you have a period of extremely high community transmission, lockdowns are intended to say we want to reduce how much exposure people have so we can reduce the number of cases that might be generated and thus reduce the impact on our healthcare infrastructure. And that makes a lot of sense. It's a very logical process. The challenge is operationalizing it, because as we learned, there are downstream implications. There's downstream implications for health, including things like mental health. There's downstream implications for things like social isolation, for child education. There's even downstream implications for other aspects of infectious disease, reducing the idea of herd immunity to regular circulating other viruses and pathogens. So is it a universal tactic that should always be utilized? No, not at all. But it is still a useful tool in the toolbox that should be really used judiciously. What's important to recognize and remember is this is the first pandemic of this size since the Spanish flu in 1918. And so there isn't really a playbook to go by to say, here's how you use these judiciously in a modern era to prevent a massive spread. And so what we should be saying is not, these don't function, these don't work, we should scrap these, never touch them again. What we should be saying is, let's look at our learnings, let's look at our successes, let's look at our challenges and say, how do we use this as a learning to better, more judiciously utilize these tools in the future if ever we need them again. So that's our first three claims down. All right. The next one's a big one. This one might be a video unto itself. We're going to do a real quick check on it. All right. mRNA jabs were dangerous. This is relating to the fact that Dr. Fauci, in his diaries, made comment on the fact that there was side effects related to some of the mRNA vaccines. And it's very true. mRNA vaccines and frankly all vaccines cause side effects, but the mRNA vaccines in COVID were attributed to potential for myocarditis, potential for vaccine-induced thrombotic thrombocytopenia, we'll just call it coagulation issues or clotting disorders. It was related to Guillain-Barré syndrome, Bell's palsy, all of these big conditions. But the fact of the matter is, those conditions are not vaccine-related problems. They are inflammatory-related problems. And so we get them from having undergone large, broad systemic inflammation. And so if we think through that pathophysiology of a vaccine versus an infection, it's the same pathophysiology. So the question then becomes, do you see those side effects at an increased rate from vaccination compared to natural infection? And in every case, the answer is no. Natural infection carries a higher risk of all of those exact same outcomes compared with vaccination. Natural infection also carries the risk of the disease, whereas vaccination significantly reduced that risk. But I digress there. The idea here is, if you could reliably guarantee that you'd never get COVID, vaccination would be an increased risk that probably wouldn't be worthwhile. But that's not the world we were living in. There was no capability to avoid contracting COVID because the intent of COVID vaccinations was never to eradicate the virus. The nature of this virus, it cannot be eradicated. The intention of the vaccine program was to progress people as safely as possible through what we call first pass immunity, the first time you're exposed to it, so that we can establish a sense of herd immunity. Not herd protection immunity, but the idea of enough immunity through the population that as it circulates, it's now an endemic virus, a regular circulating virus, not a pandemic virus. You are going to get exposed one way or the other. You have the risk of getting myocarditis, coagulation issues, Guillain-Barré, Bell's palsy, one way or the other. vaccinations in every single category provided that protection at a lower risk for all of those outcomes compared to infection itself. All right, let's go to the next one. So, COVID case fatality rate was low. This is another one that, they're twisting how things are written in the diary. There's language in the diary that looks at we may be overestimating case fatality rates, looking at deaths divided by known cases, because there may be a large number of people who are unidentified cases through the population. And we call this in infectious disease modeling the iceberg phenomenon. So if you picture an iceberg, you have the tip above the water, and that's what you can see. Those are the cases you know about. And then there's a large body underneath the water of cases you don't know about. And so the idea being that the deaths we were seeing were not being divided by that body underneath the water, and so the rate was actually a lot lower. But we can do an analysis here looking at case fatality rates of COVID versus other viruses. We can also look at case ICU admission and hospital requirement of COVID versus other viruses. And again, that takes the same assumption. It's using the visible portion of the cases instead of the entire body of infections. In virtually every study that's been done, or at least every study I've looked at recently, there is no scenario where COVID did not have an increased case severity, ICU admission requirement, hospital admission requirement, or mortality rate compared with influenza or other respiratory viruses. It was significantly higher in 2020. It was significantly higher when the Delta variant came out. It slightly decreased when the Omicron variant came out because we know that one was more infectious but less severe. And then now in a largely post-vaccine and now endemic era, it is very, very, very quickly shrinking to match COVID. It might have already kind of matched COVID. I think the last numbers I looked at were 2025-ish, and they were very, very close together. And so as we get to endemicity, case fatality rate is dropping to meet that of other seasonal respiratory viruses. But in 2020, when this was written, case fatality for COVID was absolutely not low. All right, next three, again, we'll cluster together. So ivermectin worked, hydroxychloroquine also worked, remdesivir was a killer. I don't understand ivermectin. I don't understand why ivermectin galvanized so many people, why so many people were adamant that this was the way to fix COVID. But here we are. Let's talk ivermectin. So some countries use this. Some countries used it as a treatment. Some countries used it as a prophylaxis. Latin America and Africa were some of the countries that used it the most. So countries in Latin America and countries in Africa, sorry, not Latin America and Africa are not countries per se. So countries in those regions used it the most. It's been looked at by Canada, by the United States, by Australia, by Western European countries, time and time and time and time again. It has not shown any benefit in protecting against COVID. The FDA right now, under the current administration, still has it very clearly on their website that ivermectin does not work for COVID. There is no benefit here. It's not that it was, hey, we got a new government in, finally someone who can see through the BS, and ivermectin, all of this glorious data that's been hidden comes up to the surface. The US couldn't find data, Canada couldn't find data, Europe couldn't find data, no one could find data. Same thing goes with hydroxychloroquine, but ivermectin seems to be one that galvanizes more people. Now, there is an intriguing side story to ivermectin here. In Latin America, in Africa, these are countries that have endemic strongyloides problems. So strongyloides is a parasitic infection. It can cause latent or silent, ongoing, persistent infection in us. And if you immunosuppress that person, that can lead to an active infection with significant health outcomes or death. The treatment for COVID-19, or rather the treatment for COVID-19 pneumonitis, severe COVID-19, is broad immunosuppressive therapies. We do prednisone and we do tocilizumab, a monoclonal that basically goes in and shuts down all immune signaling in immune cells. And the idea here is simple. The immune response to this virus is what's causing the problems. We want to just shut down that immune response so that the virus can be cleared out without activating massive inflammatory cascades. The problem is if you have a subclinical parasitic infection, you shut down those immune responses, your parasitic infection now ramps up into overdrive. So we actually had as protocols at one point that before or at the same time as starting tocilizumab, you had to draw off serology for strongyloides if you had a patient who either lived in or had, I think it was 6 months of cumulative time living in one of the countries around the world that were endemic. And if they were positive, you would then treat them with an antiparasitic like Ivermectin. So there's potentially something to be said about in certain nations that are highly endemic for strongyloides, there may have been a very niche off-target benefit to ivermectin in patients who are also receiving broad immunosuppressive therapies for COVID-19 pneumonitis. Very, very different story then, though, than everyone needs ivermectin if you have COVID. Remdesivir did work. It wasn't the be-all, end-all COVID treatment. It certainly wasn't the best therapeutic out there, but it had its benefits. It had its uses. It was an effective therapeutic. It was certainly not a killer. So ivermectin did not work. Hydroxychloroquine did not work. Remdesivir was a functional therapeutic adjunct. My microphone died. Let's try this again. All right, last two. So, last two we'll also group together. COVID came from the Wuhan lab and Fauci funded it. This one has been wildly whipping around, at least the COVID Wuhan lab theory here. And thanks to me having clicked on Liz Wheeler's post here on my Facebook, it's now all I get on Facebook and YouTube is more and more content that feeds into this. So thanks, Facebook algorithms. This is largely being taken, again, as misconstrued information out of the diaries. The specific language in the diaries is looking at a statement that said, from Fauci that said, we know the wet market is not the source, it is merely an amplification point. And this is being taken out of context to say that means Fauci knew it came from the Wuhan Institute of Virology, the lab that was studying coronaviruses. And that's not at all true. In fact, Fauci later said in that same paragraph, it had a animal to human jump somewhere else. It's amplifying here. And remember, this is back in early 2020. Modern science doesn't even agree with that statement. Modern science more likely contributes or more likely supports the notion that the virus jumped into humans at that wet market. If you were to actually look at, there's a really good study in 2022 that looked at all of the environmental testing for COVID in that wet market and the human cases around it. And what they found was there were actually two separate lineages of COVID actively circulating simultaneously in that wet market in different animal species. And they had separate jumps from animal into humans at different points in time. There is no reliable evidence to say that this came from the lab, either as an intentional or accidental leak. Now, that isn't to say that that isn't a possibility, but the plausible scientific the plausible scientific hypotheses right now favor the wet market being that point of origin. From the perspective that Fauci funded it, Fauci and the NIH funded a third-party corporation to do research into coronaviruses of pandemic potential. That agency then sent money to different labs, including the Wuhan Institute of Virology. The Wuhan Institute of Virology was looking at things like testing of animals for discovering novel coronaviruses, and testing of infectious coronaviruses to understand their infectivity, what drives infectivity, and is there potential that they might mutate to increase infectivity. There's nothing that sits there and says they were engineering a virus as a bioweapon threat, as is often put out. Now, does it mean that they might have accidentally created SARS-CoV-2? Potentially. But again, the overwhelming scientific plausible hypothesis is the Wuhan wet market has far more probability than an accidental or purposeful lab release. All right, we're going to leave it there for today. Like I said, we're only touching on each of these in very, very, very high level. If there's one you want to learn more about, one that you found interesting, let me know in the comments below, and we can do a follow-up video on that topic. That said, if there's any other topics in microbiology that you want to learn more about, also feel free to flip me one of those in the comments. If you like this video, please hit the like button, subscribe to the channel, and otherwise, thanks so much for watching. We'll see you next time on Microbially Speaking. Bye now.